This program is brought to you by Emory University.
Good morning. This morning we have a treat that we usually have about once a year when Steve Clements presents different cases. When Steve presents, I'm reminded of what Thoreau said, and that is, it's not what we look at, but it's what we see. And often Steve will show us things and ask us what we actually see with the images and things that I'm sure today we'll get some of this. Steve is a great teacher. I was reminded of that Friday when I went by and spoke to Susan Shepard, who's a nurse who works with Steve, and I asked how things were going, and she said, "Oh, well, things are going well, and we've got a new nurse in the area, and she's really bright, and Dr. Clements is all over educating her. He's teaching her things down in the Cath lab and the echo lab, and I think for many of us who over the years have benefited from Steve's enthusiasm in teaching, and I'm sure we will today." So, Steve?
So actually, I'm supposed to be Doug Murphy today because Doug couldn't show up, so Stam asked me if I would do it. So I'm not going to show you any surgery much, but I think when you are at a patient's bedside, or you're in the cath lab, or you're in the echo lab, or you pull your stethoscope out, sometimes your eyebrows kind of raise up a little bit and you have to hold yourself back from saying, gee whiz, or that sounds like a bad murmur, or a wow, because the patient's sitting there watching you, and you have to be very careful about how you react to that. So I've always tried to condition myself, still trying to condition myself as to how I react to things when I get surprised. And after that initial kind of startling thing, you've got to regroup your thinking and come up with an answer. So some of these are cath lab surprises, some of them are echo surprises. So this is room 2 in about the early 1980s. And you might look at this table, because in those days we could not move the C-arm. We had to move the patient. So we strapped them in, and we would tilt them from one side to the other. We could not move the II up there without disengaging the C-arm. If you wanted to get a cranial shot, you had to push the button, ask somebody to go up there and tilt it up to get what Bob France used to call a chin shot. And if you wanted to coddle, you had to tilt it down that way. It was extra challenging when you wanted to get a LAO cranial view. Now, notice in the back that there is a large screen on the left there, and there's a videotape recorder. So we did record films, but the films had to be developed. And we recorded it on 3/4 inch tape so we could play it back. So that's the way we did it then. Sometimes early on, we did digital subtraction views of the coronary arteries. That's on the left. So in order to do that, the radiologists know, and we know, that you have to have the patient stop the diaphragm. So when we look at coronary arteriograms nowadays, or ventriculograms or whatever, when the diaphragm is moving up and down like that, it's very confusing to me. The artery's moving. So you want things to be as still as possible. So that's one way that we learned how to have the diaphragms down and take the picture while the patient is not breathing. I don't think anybody does that nowadays, but it's just very confusing at times. And then, of course, there's some patients that you cannot ask to stop breathing. So on the right, you'll see the object of what we try to do. We try to demonstrate the lesion in order to plan out therapy. We get all kinds of images, and you can make them black or white by pushing a switch, and try to define lesions like that, about which angioplasty was developed. So the other thing is, you've got to look at the EKG carefully. And every time you have an opportunity to look at the EKG and compare it to the echo, look at the EKG and compare it to the coronary anatomy, look at the EKG, compare it to the left ventriculogram, then you have to look at it very carefully. And for example, this EKG. Now, I've shown some EKGs in this conference before that have T-wave changes on them, and if you were there, you heard that they can mean a lot of different things, as you know. So Paul and I grew up in the era of Willis Hurst teaching us about this, and we learned that you can plot out the QRS, you can figure out the instantaneous vector, you can plot out the T, and if you plot that out and say, is that normal or abnormal, you would immediately say, well, that's abnormal. And that T vector should not be in that position. It should be pointing up front. It's all right for the QRS to be there, but not for that T to be in that position. So when that T is in that position, it has a special significance, and it's not specific, but it can mean several things, and you've got to choose the one that's important. So you got to know the anatomy, not only in the Cath lab, but in the echo lab, and how to translate this to a colleague or to a patient, an intern, a fellow, and importantly, to a patient. So maybe a good drawer. All of us draw the mitral valve, the coronary arteries in a different way, but it helps a lot to draw a picture. And as time goes on, you develop your own way. I've always watched John Douglas draw. He does open the coronary arteries. He comes down with the LAD and the septal perforator goes like that, around like that, the diagonal up like that. Or I like to draw them like with stick diagrams like that. And a family appreciates that when you talk with them. And, something like that is what I like to draw. So, for example, this is a 68-year-old gentleman who presented to an outside hospital. And that was his EKG that you just saw. And now he is ready to go to the Cath lab because he's having discomfort. So you take him to the Cath lab, and you decide to shoot the left coronary artery first. And you do that. And you see some low-hanging fruit up there. See a very tight lesion in that vessel. So you say, well, that's low-hanging fruit. He's having discomfort. His troponins are not very elevated. So I think that we will just wire that artery up. So we wire it up. Things look good. That's a very discrete lesion. And we line up our stent. And we put our stent in there. And we get ready to take our final picture. And we take the picture and we try not to be surprised. We try not to say, uh-oh, because there comes another vessel down within the shadow of the heart, not on the margin of the heart. And once you see that, you realize that what you've done is open the diagonal and you jail the LAD. But by then, the pain is stopped, the LAD is open, the diagonal is open. So now what do? You have jailed the LAD. So you try to wire that up and you can't do it. Patient's feeling a little better and you just kind of hung up. So then at that point, about a month later, you appear in my office and I have to kind of adjudicate that a little bit. So where is the diagonal? And why should we not have recognized that? So the diagonal is on the margin of the heart in the RAO view. If you like to start your procedures in the RAO view, the diagonal is on the margin of the heart. There it is there in blue, hanging out on the margin, and the LAD is within the margin of the heart. And that's what you saw a while ago in that arteriogram. You saw the LAD within the margin of the heart, the diagonal on the margin of the heart. And once you commit to fixing that diagonal, if there's an LAD right there and you put a stent in there, then you jail the LAD. So the diagonal in the RAO view is on the margin of the heart. The LAO view, of course, they had those too. The diagonal is headed out to the left. The diagonal can be a very large vessel. Usually does not have septal perforators. Sometimes has several diagonals. It causes difficulty, especially when it gets jailed. And there's stories about that. When you jail the diagonal, your patient comes back and forth with chest discomfort. The nuclear studies are abnormal, and it's just a dilemma. You don't want to operate on that. You can't get into it without jeopardizing the LAD or putting in a lot of hardware. Usually it shows up in the lateral leads and not the precordial leads like that. Like in this EKG, look at lead 1 and lead AVL. And you see the T waves are turned to the right, as you saw in that other vector diagram. And the ventriculogram is also helpful. When the diagonal territory is hung up, the anterolateral wall is hypokinetic. Our echocardiographers know to tilt that over and start looking in the two-chamber view for the diagonal. You might not see it in the parasternal long axis view. The apex comes in and leaves that area hanging out there. You don't see that much in the LAO view. So the diagonal vessel in this situation is missing. The apex is coming in. The anterolateral wall is hanging out, and that's the diagonal territory. And it's right out there that on the margin of the heart in the RAO view, the apex is coming in, so we've got the correct anatomy. We know that T vector is turned to the right in contrast to that T vector in this particular electrocardiogram. So that's telling us there that if you're wondering what the culprit vessel is, it's the LAD of the diagonal. If it's the red arrow, it's the diagonal. If it's the black arrow going posteriorly, it's the LAD, and it came from the green arrow that turned posteriorly. So in that final shot, you saw that. You see the diagonal up on the margin. In that later shot, see the LAD coming within the margin of the heart. So that's a little lesson about the diagonal, which I'm sure you've never had before, except maybe a little word or two in the cath lab, but it can get you in trouble. So we're going to change the subject there. We have to do cardiac catheterization sometimes in patients who have bypass grafts. And sometimes the patients know where their bypasses are, and other times they don't. So you start looking for markers. Some surgeons put markers on and some don't. You say, where are the markers? Where do we start? Is the creatinine elevated? Are we compromised from the standpoint of being able to do an aortogram? So the next gentleman was one of my favorite patients. He's a tennis pro, and he came in with some chest discomfort, and things evolved such that he had to go to the cath lab, and he said, well, I had 4 bypasses. They were up in North Carolina. I said, do you by any chance, it was a long time ago, do you by any chance know where the bypasses are? And he said, I'm afraid I don't. So we started out, said, well, maybe we'll just step on the fluoro and it'll tell us. So we step on the fluoro, and we see nothing but little clips. And little clips are everywhere. You know, little clips are down here. Little clips are down here, they're out there, and there are no markers. So, no markers, the clips are all small. We can't find anything on the aorta when we search it out, so now what do we do? Now we know that the surgeons use little clips to put on the mammary pedicle. and they use larger clips to go on the vein grafts. So that makes us suspicious that something's going on here with the mammary. So we go up and start after the mammary. And we shoot the mammary, and we try to hold ourselves back for a moment there because we suddenly are surprised. And we realize that this surgeon has taken the mammary, probably both mammaries down, and he's created a situation where he does a jump graft from the diagonal to the LAD. He's sewn the other mammary onto that mammary and put it down to 2 marginals. So that's his whole bypass operation right there. This was about 15 years old, and it turned out to be a wonderful operation. Not many surgeons can do that. So that was an extremely talented surgeon with an internal mammary going as a jump graft, side to side to the diagonal, terminating in the LAD, and then down as a side-to-side graft in the marginal and terminated into the posterior margin. Fantastic operation, but very confusing when you don't know where those bypasses are. The other bypass grafts that are confusing, for example, the Y grafts and the snake grafts. There's one surgeon in the southeast here that used to like to do these snake grafts. And when you saw his name, you might as well start looking for it. Otherwise, you're going to get extremely confused. So snake grafts, for example, may start on the right, and they're side-to-side anastomoses between the PDA and the marginal branches may go up and terminate in the diagonal of the LAD. Now, the trouble with that is if you get a lesion proximally, all your bypasses are compromised. So there's some jeopardy involved with that. Now, the other situation that we see is the Y grafts. Natural Y grafts work well, but surgical Y grafts don't work as well. If you're looking at the fluoro, when you do have the benefit of markers, various ones of us like to do this in various views. For example, in the RARIO view, that you're looking straight at the marker on the Y graft and looking at the markers on the edge of the aorta for the OM grafts and the diagonal graft and the LAD graft if it's not a mammary. In the LAO view, it's out this way on the left, and these grafts, you're looking right at them. And we teach you guys that to get the right graft that you counterclock your catheter, and to get these grafts, you clock the catheter. So you have to count your arteries when you're looking at arteriograms. You say, where's the LAD, where's the circumflex, and where's the right? So here we go, and we inject the right, and that is 1. And we go over to the left, and we inject that, and that is 2. We already shot the right and the left. Where's the third artery? So there are 2 clues to this. Number 1, in this view, there is no circumflex. That is a septal perforator. Now, how do you know that? Well, it looks like a septal perforator. Number 1. Number 2, the circumflex is actually missing. So then you have to go back and search out. That's a closer look at the left. You have to go back and search out the right, and as you use the multipurpose catheter and kind of clock it around, you wind up hitting that, which is the anomalous circumflex. 1 in 100 patients have that. That's the most common coronary anatomy anomaly. So there's another example of that. It's a big surprise when you see it. If you do a ventriculogram, you look at that ventriculogram, there's a very famous sign that you see with that. If you look down in that region, there's a little dot. That's called the dot sign. And the dot sign gives you the first clue to the fact that you have an anomalous circumflex, and you can't give up until you find it. We see that on transesophageal echo. when there's an anomalous circumflex, it courses back posterior to the aorta. You know, that's the aorta is back in the back. I mean, the left atrium is back in the back of the aorta, and the anomalous circumflex is right there. And if you look at that in another view, you can see the artery coursing over behind the left atrial appendage. Is my pointer working up on that? Yeah, it's looking. It's not working. It's working there, but it's not working there. Okay. Well, the circumflex is up there coursing over the left atrial appendage, and that's the left atrial appendage. So that corresponds to what you saw with the angiography. So that's the most common anomalous coronary artery. Now, the most famous of all anomalous coronary arteries. I'm sure you know that. The most famous of all anomalous coronary arteries. You got that in your mind. So it's a bit discouraging when you start looking for coronary arteries and you inject some contrast in the left cusp and you don't see a coronary artery. So one time Dr. Hurst had this patient. I was doing the cath. He was sitting up in the control room watching. And we put the catheter in the left cusp, we injected dye, and there was no artery. So I looked around at him, and he looked around at me, and I said, well, we've got to look somewhere else. So maybe then you start looking. On the right side, you find an artery there. I said, well, you know, I've seen the left cusp. There's nothing there. Now I'm looking at the right cusp, and I see something that does not account for all the arteries. So you've got to do some more looking. And if you continue to look, you'll find something very large on the right. And large right coronary arteries mean there's a fistulous connection. When there is a fistulous connection, sometimes it's connected to the pulmonary artery. Therein is why I say this is the most famous of all coronary arteries. So this is a large right coronary artery that fills the left by collaterals, and the left comes off the pulmonary artery. And there's the CT, the rendered CT of that. The LAD arising from the pulmonary artery, the left coronary artery arising from the pulmonary artery. And that has a very famous name associated with it. And I've asked this on rounds before. Many times I don't get an answer, so I say, well, go look it up. So in 1933, Bland, White, and Garland described this. In newborns who have myocardial infarctions, they have heart failure symptoms, and they cry when they feed. So that's the most famous coronary anomaly of all, in my opinion. So I know all of you know what the Tet artery is. You know what the Tet artery is. So I know you have the answer to that in your mind. What is the Tet artery? So this is one of my favorite patients who I've dealt with for about 20 years now, and when we cathed him, that's what it looked like. We were in the right cusp, we injected this artery, and it went over, and suddenly the LAD filled. Now that's not a collateral because that artery has branches. It goes straight across the conus to the LAD. Actually, he's got a total right. And eventually he had to have bypass. He did not have tetralogy, but this anomaly is seen in tetralogy. And Dr. Follow and Dr. Steno knew about this artery as they dissected things out, and they found not everybody with tetralogy, but a number of people who have tetralogy will have this anomaly. And it's important to know about this anomaly, since if you're doing a total correction on tetralogy, and you make that in red line incision there, it'll go right through the artery. Now, as you know, as you've been down to the operating room and in the pathology room, you don't see the arteries on the surface. You kind of see where they are, but the epicardial fat covers them over. The epicardium covers them up. So you won't see that artery. So you make your incision right through the artery you go, and if you're not a bypass surgeon, suddenly you're in a lot of trouble. So you have to know about that artery, and you see variations of it in people from time to time. So Tetralogy of Follow, as you know, is what you ask your medical students around. So you know what Tetralogy of Follow was, right? And so you need to name these 4 abnormalities, and then I'll show it to you. You need to know that the blue blood mixes with the red blood and goes out the aorta, and the amount of it that goes out the aorta depends on the systemic vascular resistance, and that's what squatting's all about. In this example here, you can only see 2 of the components, like you see the overriding aorta. Overriding aorta, the right ventricle, the left ventricle, the aortic valve, mixing right there. So Tetralogy of Follow and the Tetralogy artery. Now, in talking with the fellows in the echo lab, I realized that they never have heard of Trilogy of Follow. So the Trilogy of Follow is a situation you get when you have an atrial septal defect and valvular PS. And then I realized that they had never heard of Luton-Bachet syndrome before, which is an atrial septal defect / PFO and mitral stenosis. Of course, the mitral stenosis is acquired. And you see that down in the bottom here. You can imagine the physiology that's provoked when you have that. So Trilogy of Follow and Luton-Bachet syndrome might get you the answer to a question or 2 on your boards. So another surprise. This next gentleman is a neighbor of mine, and we'd been working on the situation, and somehow he eventually wound up in the Cath lab, and we injected his right coronary artery, and we had to kind of hold back a little bit because the contrast went into a deep, dark hole. And I actually had a couple of these patients. One time I went out of town, and Jerry Lutz and Hisham Balbaki were cathing this patient, and they said, well, they had a multi-purpose in, and they counterclocked it around and went down into a deep, dark hole. I said, well, you injected some contrast, right? He said, no, we pulled it out right quick and find some other way to do it. But so this man, I actually had been following him a number of years. I knew that he had an aneurysm of his right coronary artery. That is an aneurysm of the right coronary artery. A few years before, it was that size, and Peter Block and John and I had all discussed about what we should do about this. And we said, well, you know, do coronary aneurysms, they really enlarge? Have you seen one enlarge in front of your eyes? And actually, I didn't really think so very much, but I was dead wrong, because this one did enlarge, and we started out with a CTA, and I started getting phone calls about this giant aneurysm of the right coronary artery. Hope you can pick that out. And the 3-dimensional rendered view of that shows this large sausage-like thing on the right coronary artery. So we pondered over what to do, and finally we decided that the coverage stent was not long enough, that he needed to go have an operation, and Bob Guyton took him to the operating room. You might think that you could see this artery on the surface, but like we said before, the epicardial fat is there and is not that exciting. So the aneurysm is right here. And Bob was able to get control of the situation, bypass the distal right, ligate both sides of the aneurysm, and we took it out of the circulation. So that was our situation with a giant aneurysm of the right coronary artery. They do enlarge, and I assume if they continue to enlarge, they can rupture. Have we ever seen one rupture? Not really. So sometimes there are unusual connections. Not long ago, someone walked up to me and showed me one of these connections. Now, when there are connections in the chest between arteries, coronary arteries, or other arteries, and veins, they cause continuous murmurs. You know, continuous murmurs are not continuous. They start in systole, they extend through the second sound into diastole. They don't necessarily have to go all the way. Aortic stenosis, aortic regurgitation is not a continuous murmur. But some fistulous connection, in which there's a constant gradient between the arterial circulation and the venous circulation, almost continues, and it causes a murmur that bridges the second sound, continues well through into diastole. So coronary AV fistulas are one cause of continuous murmurs. I know you have these in your mind now. Patent ductus arteriosus may be one of the most famous one, but probably the most common one is a ruptured sinus of Valsalva aneurysm into the right ventricle, which causes something that sounds like a train going by in the chest. So the other day somebody walked up to me and they showed me this, and I said, well, you know, you've seen that before, right? Maybe occasionally. And then they said, well, not really. So this individual is someone I've worked with for a long time, and she has coronary to pulmonary artery connections on both sides. One has to kind of adjudicate the situation such that you determine whether or not you're stealing away from something. And if you are, these can be coiled, and you can get rid of them if it's done carefully and you don't thrombose the native artery. We see these in the echo lab from time to time. For example, in the right upper there, you see this turbulence coming in from somewhere. PR is right close to that, and the one on the left lower there is this jet shooting in from the lateral side, as you see in the left lower there, and the PR is down in another area there. So those coronary to pulmonary artery connections can be identified on echo, and they're not terribly uncommon in the Cath lab. Most of the time, we leave them alone. So the left ventricle can be connected to things also. So what can the left ventricle be connected to? Well, what can the left ventricle be connected to? Well, it can be connected to the left atrium by mitral regurgitation or by something else. Be connected to the right ventricle, can be connected to the descending aorta, can be connected to an LVAD, can be connected to the coronary sinus. That sounds unusual. Can be connected by some other circuitous pathway. So this is a lady that we had a long time ago, in which we did this ventriculogram. As you see, she has a mitral prosthesis there. That's a Hancock valve. And that prosthesis has been replaced at least once. See, she's got epicardial leads on down there. So we inject the left ventricle, and we see something else filling out along the AV groove there. And as it turns out, she has a fistulous connection around her valve into her coronary sinus, which courses back and empties into the right atrium. So this is a left ventricular to coronary sinus connection. You can imagine the endocarditis might cause that. And from the other side, you can see it going up laterally into that kind of pseudoaneurysm-like area. Coronary sinus coursing down and filling the right atrium. So here's another situation that's a bit puzzling. So when you start advancing your catheter one place or the other, you need to know where it's going without, you may or may not be injecting dye. So you need to know where it's going. For example, if you have an atrial septal defect, you're coming up the vena cava, next thing you know, you're in a pulmonary vein. You say, where did that go? So are you outside the heart? That's your first thought. No, so I'm inside the heart. If you can't figure out what's going on, it's oftentimes a good idea to inject a small amount of contrast. So looking at this catheter course, I've asked some of you what cathetercosis was. It's extremely puzzling. So it has a balloon on the end of it, and we just put a little contrast through it and let the balloon down, and suddenly the venous system of the heart fills out. So we have a Swan-Ganz catheter coming up the aorta, going into the right coronary artery. Right coronary artery is very large. Coronary arteries are very large, oftentimes have fistulous connections, and that one had a fistulous connection also to the, very confusing if you don't use that and don't let that bolus go through. And actually, anatomically, this is what that looked like. You can see in the back that down at the bottom, it connects to the coronary sinus. This was very difficult to deal with, but that's a right coronary artery to coronary sinus fistulous connection. So on another day in the cath lab, if you inject the right coronary artery, you try to hold yourself back from saying, uh-oh, what was that? And you see this large clearing aneurysm-like area there. Is that the sinus of Valsalva? Is that part of the coronary circulation? Or what? If you do a ventriculogram, you see the big dot sign. You saw the little dot sign, this is the big dot sign. And the echo will help you separate that out. Something adjacent to the aorta there. And you put color flow on it, and you see there's turbulent flow into that, and this turns out to be a coronary artery to right atrial fistula with the right coronary artery continuing beyond that. Another patient, I don't see Larry in the audience, but Larry worked with this patient, so he must have been surprised when he made that injection. Saw this large artery. The patient already experienced an inferior MI, and we did some testing, Larry and Peter Block, and they decided that this coronary artery was leading to an area that was not viable. And after defining this on echo, another large circle in the heart can be a coronary aneurysm. So this was wired up. And under echo guidance, coils were placed in the right coronary artery, and the right coronary artery aneurysm thrombosed off, and the patient never had any chest discomfort. So that's another example of a right coronary artery aneurysm, and that's how we dealt with that one. So it can be masses in the heart. If you're suspicious about a mass, then you do an arteriogram or an echocardiogram with contrast. We're looking to see whether or not we can tell about the vascularity of that. And I've shown this many times here, but when you inject the right coronary artery or left coronary artery, and you see this kind of moving jelly-like area that's got a lot of venous sinusoids, then that's a picture of the arteriography of a myxoma. If you look at that under the microscope, it's interesting because these big venous lakes in these tumors, some of the myxoma cells line up around the vessels. They like to be perivascular, and that is microscopic of that. Otherwise, the cells are sparse, they're long, they're multinucleated. So that was an atriomyxoma. Now, how about this? For example, this is a left coronary artery injection, and up in the area of the left atrial appendage, that's where the left atrial appendage is in this picture, there is some blush. You say, well, myxomas are not supposed to be there. This has got to be something unusual. So part of the workup was an MRI, and the MRI showed something unusual that was at least in part stuck to the anterior mitral valve leaflet. The echocardiogram had shown that this was coming from the left atrial appendage. Duke Wynn scraped this off the mitral leaflet and pulled it out of the left atrial appendage without cutting through the AV groove there. And the microscopic of this showed this terribly disorganized, multi-type nucleated tumor that turned out to be a sarcoma in this wonderful nurse. And she was started on chemotherapy, and by 7 months later, she was no longer with us. So sarcomas of the heart are not good things. So another lesson we've learned is to take the blood pressure in both arms. Not too long ago, the nurse practitioner, a little bit choked, came up and said, well, I've seen this patient, and he's had coronary bypass surgery, number one. Number two, he has a different blood pressure in one arm versus the other arm. He's 140 in one arm, he's 60 or 70 in the other arm. I said, what does that mean? So I asked some more questions, of course. But we knew that when you're in the Cath lab and you inject the left coronary artery, and the mammary fills reasonably promptly, and it fills right up, then something's going on, because it's supposed to be washing out in the artery. So when you see that, what do you look for next? There it is right there. You pan up and you see that the mammary is connected to the subclavian. And flow is not right in that mammary, so you have a plan for the next shot, and the next shot you inject in the subclavian, and the subclavian is stenotic. And you call on Trang to look at the flow in the vertebral, and the flow in the vertebral has the wrong color. That color, they look for red back there when they turn the transducer immediately, not blue. So blue means that flow is in the wrong direction, and you have retrograde flow, as you saw. And in the digital subtraction study of these kind of individuals, you see the subclavian in this situation totally stumped off down there. And if you wait a little while, you'll see flow coming down the vertebral and filling the arm artery. So not only are you stealing from the circle of Willis, but you're stealing from the heart. So with a little luck, you can get these opened up. And once you open that up, internal mammary flows down that way, and the vertebral flows the other way. So, when you're in the Cath lab or the echo lab, you got to be prepared. Try to study your patient ahead of time. You got to keep your eyes open. You got to keep your brain working. You got to stop and think. You got to know your anatomy from all angles and all views. And every patient you see, you have to learn from. Thanks.
Thanks, Steve. That was wonderful. Just a question. You talked about being surprised in the Cath lab. I guess one way not to be so surprised is to have had the good physical exam and be looking for something, but sometimes you do come across things that you don't expect. Could you give us a little bit of a sense of how you communicate with patients during that time when you're sort of in an uncomfortable situation as the doctor doing the procedure and trying to think through things, and you're talking to people in the lab? What do you think about as far as the words you use in communication?
Well, as I said, you got to try not to say, uh-oh. You got to try not to say, oh, no. And you got to remember that most of the time they're listening, the patient's listening when you're talking. And sometimes when you encounter something that's going to cause you to change your course entirely, you may have to break scrub and go out and talk with the family. But if you're listening to a murmur at the bedside, you don't say, well, gee, that's a bad murmur. That's an awful looking thing. You have to say, well, here it is. It looks like it's large. It has a lot of structures adjacent to it. We have to be very careful about that. The determining factors about how we deal with this are this, that, and the other. And you have to speak to them on a one-on-one basis, and you have to speak their language. So that's how I try to do it.
Steve taught me early, it's not what you say or how you say it, but it's how you're perceived and what the patient actually hears. And I was reminded when I had first started here with as sort of the expert in heart failure, and patient asked me, patient with dilated cardiomyopathy said, what's the cause of this? And I told the patient, I said, well, we don't know the cause. And patient walked away, and Steve came up to me and said, Andy, what that patient heard was that you don't know the cause. Okay, and they're going to go to somebody else who's going to tell them that it was due to a virus or something like that, which probably isn't true. It's better to say the cause is not known. And Steve has a knack with words and getting helping patients to be comforted, and I think we can all learn from him. Other questions or comments? If not, then another thing I would ask Steve is you collect things. You collect interesting cases, and if you could sort of give us an idea of how you do that, what processes you use, and because I think I've seen a lot of interesting things over the years that I have not kept track of and recorded. But what's your process to do that?
Well, like I tell Frank and all of his buddies, that you have an opportunity. First of all, it's a learning opportunity. And, you categorize these things in your brain. But you have an opportunity now in the digital age to collect these things a lot easier than it was in the past. In the past, you may have a photograph, or you may have a 35 millimeter slide. I have a lot of 35 millimeter slides. But, somehow I've got to get those to the digital age one day. But you need to have some organized way to do that, I think. And the opportunity is there. It's just a matter of doing it. You may not have to collect much of it. You may just have to collect a clue to it. And write that down somewhere, or have a place in your computer that you put that so you can refer back to it. I'm always referring back to those little things, and I'm maybe a collector, but I'm an incomplete collector. I'm not, I can't always come up with what I remember from the past like you guys, but I think it's a good idea to do that. It's material that will be valuable to you in the future. And yes, we published things recently, some of which have been around for years and years and years. So that's the way you learn. I think that's the way Paul Dudley White learned. If you go in that room, you'll see something framed, and you'll see how he collected things. He collected them on 3x5 cards in a little box, and there were handwritten things in there. One of the patients that on the board in there, or in the framed area, is a patient by the name of David Clements. That attracted my attention. And he had notes on it, and that was the way he kept up with things, and that's the way he learned. I know Dr. Hurst learned that way because when he started publishing that book, he knew everything in it. And that was his way of collecting.
For those who know Dr. Bob French, he used to keep a little card of every patient he had Cath, and I would see somebody who might have needed a transplant who had congenital heart disease, and he'd say, Andy, what was her maiden name, and tell him the name, and he'd go back, oh yeah, I remember that patient. I cathed her when she was 6 months old, or that sort of thing. So very interesting. Any other Habib?
So I just want to echo what's said, and I want us to, at Emory, celebrate the sort of heritage of learning from clinical cases. And as you look around the country, frankly around the world, there aren't many places that have this heritage, the tradition of going back and learning and sharing. And Steve obviously is our master now of that. But also in the current age, we do have to share the data. And so one incentive to collect it is that there are a lot of opportunities to publish case reports, to share it amongst ourselves, and then to collate them. One could imagine a fellows collation once a year of interesting cases that perhaps the chief fellows could look into. Just
Thank you.
All right, thank you very much.
The preceding program is copyrighted by Emory University.